Good morning, everybody. We'll start the session of diabetes in Asia. And for the first speaker, do we have the first speaker? Dr. Abdullah Hamak from Qatar. He's MPH, PhD. He's currently Executive Director of Qatar Diabetes Association, Foundation for Education. He was elected the Regional Manager of IDF in 2010. He was a president of Diabetes Asia Group till 2011, a fellow of Royal Society of Public Health, member of Advisory Committee, College of Health Science, Qatar University, member of American Diabetes Association, member of EASD and ACE, General Secretary for the Gulf Group of Study of Diabetes. Dr. Al-Hamak participates in research activities with Weill Cornell Medical College and Hamad Medical Corporation in the fields of diabetes. Most of these studies have been published in international journals. Over to you, sir.
Prevention program in Asia. The prevalence. First, I would like. Okay. First, I would like to thank the organizer for inviting me for this conference. Okay, I will talk about the challenges in diabetes prevention program in Asia. Next. So just to give you highlights about the prevalence rate in the world. So this is IDF estimated that 1 in 10 adults aged from 20 to 79 years has diabetes. This is now about 537 million people are suffering from diabetes. And 1 in 8 adults aged from 20 to 79 has impaired fasting glucose. That's estimated about 390 million people. And 3 in 4 people with diabetes live in low and middle income countries. So 1 in 2 adults is undiagnosed, about 240 million people, and 1 in 6 live birth affected by hyperglycemia in pregnancy. About 80% have mothers with GDM, and about 9% of global health expenditures spent on diabetes is about 967 billion in US dollar, and 1 in 10 adults aged between 20 to 79 has impaired glucose tolerance, about 541 million people, and about 100.2 million children, adolescents below 20 years old have type 1 diabetes. Now about 6.7 million deaths attributed to diabetes. Next, please. Okay, now about the impaired glucose tolerance, we have 1.67 million, and about the that expenditure about 206 billion spent in diabetes. We have about 700,000 pregnancies affected by hyperglycemia, and 7.8 million more adults with diabetes undiagnosed, and about 149,500 more children and adolescents with type 1 diabetes, And we have 2.5 million more deaths caused by diabetes and 73.6 million more adults with diabetes. This is according to the last Atlas edition 10 is published in 2021. Next, please. This give you the broad spectrum of the diabetes in the region. So with different colors, so you can see the prevalences is actually increasing from America to Asia and to Africa. Next, please. This slide is also just illustrated that the diabetes is rising worldwide, and it is set to rise even further. So if we start in 2000, we start with 151 million. So when we reach to 2021, it's come to 537. So and the projection to the global prevalence of diabetes in the age of 20 to 79 years age group in millions. So in 2250, it's come to 335, and in 2045, it's come to 700 million suffering from diabetes. Next, please. Okay, let us just look to the Asia map. Next. So the IDF South Asia SEA region includes 7 countries and territories, currently representing about 11 diabetes organizations in 6 countries. It is the second most populous IDF region. Next, please. So about the Southeast Asia region, this is the highlights of what is about diabetes. So 1 in 11 adults have diabetes, about 90 million. India accounts for 1 in 7 of all adults living with diabetes worldwide. And the number of people living with diabetes to increase by 69% to 152 million by 2045. Over 1 in 2, about 51.2% adults in living with diabetes are undiagnosed, and diabetes is responsible for 747 deaths in 2021. The total diabetes-related expenditures in the region, I mean the Southeast Asia region, is about 10 billion, the second lowest of all IDF regions. And 1 in 4 live births are affected by hyperglycemia in pregnancy. Next, please. So this is the same. It is the figures in Southeast Asia. So if you look to the map about the IDF in Asia region will increase 68%, as I mentioned. It's about 152 million, and by 2045, 45, and the proportion of undiagnosed diabetes is the 3rd highest of the IDF region at 51.2%. Only 10.1 billion USD was spent in diabetes in the Southeast Asia region. Next, please. So the proportion and the number of adults who died from diabetes before age of 60 is about 6.9%. In the IDF Southeast Asia region in 2021. This is according to the last atlas. The proportion of the region, the proportion of the pregnancy affected by the hyperglycemia is the highest among IDF region at 25%, 25, almost 25%. About 10.1 billion was spent on healthcare for people with diabetes in IDF Southeast Asia region in 2021. Next, please. Okay, this is the top countries actually. So they put it in so the highest one is India, 61.3 million. The second one is Bangladesh, is about 8.4 million. This is in 2011, and in 2021 is 13.1 million. Sri Lanka is 1.1. This is in 2011, and 2021 is about 1.4 million. Nepal is 488, and in 2021 is 1.1. Mauritius is 138, and in 2020 is about, it's a double, 250.400. Next, please. So by country, if you look to the countries, because for example, China is, because it is in Asia, it's about 140.9 million, has the largest number, followed by India. So first China, and then India, and the Asian countries, other, including Pakistan, Indonesia, Bangladesh, are among the top 10 according to the Atlas, IDF Atlas. Next, please. This is show you the top 10 countries, not only from Asia, but also from other countries. So, for example, number 1 is China, number 2 is India, 3rd, Pakistan, 4th, United States of America, and then the 5th is Indonesia, 6th is Brazil, 7, Mexico, 8 is Bangladesh, and then 9, Japan, 10th is Egypt. This is in 2021, and then in 2045, it's there. There's a change. Second, the 10th is Egypt, but in 2045, Egypt will come 9th, and then Turkey will join the top 10. Will be the 10 of the country is increasing in diabetes. Next. This is come from EASD and also from the American Diabetes Association. Show about the number of the promoted research from the Asia. So in Europe about 55 million, Middle East about 55, Asia about 251, North and South America is 80 million. This is for the better diabetes care in Asia. Next, please. Okay, this is the showed from Mr. Abdul Ghaffar. They show that the number of the people, number of diabetes in thousands. So you mentioned, you will notice that the increasing from 2000 to 2025, there is a very much increase in the numbers from Bangladesh up to the Sri Lanka. Next, please. I remember the IDF is emphasized in the National Diabetes Prevention Program. They ask all the countries, either in the Southeast Asia region or in the Middle East region, to have the DPP. This is very important because by this program, you can tackle the diabetes, prevalence diabetes, and also to have a program focusing on the preventions. Next, please. So the DPP, according to the IDF, is an evidence-based lifestyle change program for preventing type 2 diabetes in those at high risk. This program actually is it provide an infrastructure to facilitate collaboration among federal and state government agencies, community-based organizations, employers, insurers, healthcare professionals, and academia and other stakeholders. Next, please. Next, please. Okay. Now let us look to the no before the previous slide, please. Okay. So there is a different program actually in the world focusing on the lifestyle changes. For example, in China, they have Darkwing group-based RCT was the first longest running of such studies. It began in 1986 with a follow-up study conducted in 1997 to 2006. The study actually demonstrated a 43% incidence reduction in the intervention group after 14 years when compared to the control group. It's a very, very successful prevention program in China. In the US, they have what we call it DPP, the US Diabetes Prevention Program. It is began in 1996. The study found that lifestyle change interventions focus at 4.7 weight loss and moderate increase in physical activity over 1 year achieved about 58% relative risk reduction in type 2 diabetes, and that use of the metformin achieved about 31% reduction. When compared to a placebo, the TPP use in terms of 1-to-1 counseling with the minimum of 50 racially and ethnically diverse individual across both male and female genders at high risk for type 2 diabetes, elevated plasma glucose about 95 to 25 millimole on fasting glucose of 7.8 to 11 millimole. Next one. Next, please. Next slide. Okay, and there is other program actually in Finland. They call it the Finnish DPS, and actually, no, please, the previous slide, please. The previous slide, please. Okay, thanks. So we have, as I mentioned, that there is also a prevention study program in Finnish. They call it Finnish DPS, and they started in 2001. Tested lifestyle intervention in a community-based primary healthcare setting, and designed and implemented at high-risk screening system for type 2 diabetes that is used worldwide, called the Finnish type 2 diabetes score. The study demonstrated, is very important, at-risk reduction of 58%, as well as a legacy effect of 43% reduction in type 2 diabetes in 3 years after completion of the study. In Japan, also they have one, they call Japanese DPP, conducted in 2005 in male participants with the IGT more than 150 milligram per deciliter, found a cumulative 4-year incidence 78 beige 2 of 11 currently died about 2019, about 1970 diabetes of 9.3% in the control group versus 3% in the intervention group. Next, please. Next. Okay, let us now go to the India. India, they have also they have a very good diabetes program, Indian DPP1 trial. That's what is conducted in 2006. Was a community-based random involving 531 subjects with IGT across 3 interventions arm. One was given advice on lifestyle modification. One was treated with metformin, and the other was given the lifestyle modification plus metformin, and the one control arm. A relative risk reduction from 26 to 29% after 30 months was similar in 3 interventions arm. Addition, 3-year results suggest that both metformin and lifestyle changes were cost-effective in preventing type 2 diabetes. Next, please. Next. Okay. Okay. I was just going to give you an example of the from the MENA region in my country, Qatar, in my country, Qatar, what they call the Qatar Diabetes Prevention Program, QDPP. It's a research project expected to transform a way for diabetes prevention. Will start recruitment of subjects early in 2020. The research program aims to identify the best method to predict, prevent, and reverse type 2 diabetes. The 5-year program is funded by Qatar Foundation and Qatar National Research Fund and co-funded by the Hamad Medical Corporation. The QDPP research project supports the National Diabetes Strategy led by the Ministry of Public Health. Next, please. Next. The QDP is composed of 7 complementary sub-projects. The project number 1 is aimed to prevent the progression of the pre-diabetes in type 2 diabetes into type 2 diabetes. The project 2 is aims to find the best method to prevent gestational diabetes in subject with diabetes risk factors discovered by the pre-marital screening. Project 3 is aimed to find the best method to prevent progression of gestational diabetes into type 2 diabetes. Project 4 is aimed to achieve diabetes remission in patients with newly diagnosed type 2 diabetes. And then Project 5 aims to identify genetic factors associated with pre-diabetes and type 2 diabetes. And Project 6 aims to identify the proteomic and metabolic markers associated with the pre-diabetes and type 2 diabetes. Project 7 is aimed to develop e-health tools and mobile application to support lifestyle intervention for diabetes prevention and management. Next slide, please. Next. Okay. There is a transform a digital diabetes prevention program. This is a new concept that transform, integrate interactive mobile compound example, smartphone application, wearable tracking device example, activity tracker, remote health monitoring, hardware example, digital scale, and professional health coaches to effectively address the complex factor that impact behavior. Transform is a 12-month intervention that uses the same 2-phase program structure as the CDC's program, a 16-week high-frequency core intervention followed by 8 months of complementary maintenance program to support the new health behavior. Next, please. There is a very important factor that we always, one of the challenges is the policy makers. So the policymakers face a number of challenges when they attempt to implement changes needed for improved management and prevention of diabetes. Next, please. Next. Okay. Also, one of the challenges is about the health service reform. The effective surveillance and management of diabetes may require rethinking traditional model of healthcare. The ideal model is one that takes an active approach to support patient health over the long term and a positive role in activating behavior change. Then the second one, we have also disease versus broader health focus. To gain support for the prevention of type 2 diabetes, policies need to include broader cross-disease perspective that concentrate on risk factors rather than on the disease. That's a very important point. This approach creates a more compelling and consistent program for action. Next. Next. Okay, now we have the health ministries versus cross government. Many elements of the diabetes care are managed by the health ministry. We know that. However, the wider preventive agenda calls for a cross-departmental approach that involves other ministries such as education, planning, transport, and industry. Long-term frame, turning the tide on diabetes will take longer than a single parliamentary cycle. Therefore, the emphasis should be on developing and embedding coordinated multi-party commitment to action that is sustainable over the medium term. Next. Next. We have the tailored approach. There will be no one size fits all solution. Suitable intervention differ from country to country, align with the country's different cultures and degree to which they already have an environment focused on prevention. There's other challenge is the prioritizing, carrying out the extensive agenda for managing and preventing diabetes require both time and resources. To secure this, it is necessary to make diabetes a priority for both the public and the politicians. This is not an easy task, given the competing priorities that these groups have. Next one. Next. Okay, the policy goals. So now let us look to the policy goals. Next. So the key goals for the policy makers: minimize and reduce the risk of type 2 diabetes and its complications by increasing knowledge, skills, support, and access to the quality services. Very important, and reducing environmental risk. Next. Okay, primary prevention of type 2 diabetes in South Asia, challenges and the way forward. Next. Challenge. Okay, we have to translate the research funding into community-oriented upstream programs poses a huge challenge because of the following characteristics. South Asia is a diverse region with a huge population consisting of nearly 20% of the world population. Number two, existence of the varied rates of literacy, poverty, socioeconomic disparities, urban, rural, and cultural differences. 3. High risk for type 2 diabetes, cardiovascular disease, hypertension, and associated metabolic disorder. Metabolic abnormalities develop at young age. Therefore, preventive strategies have to be started in early life. Next. Okay. This is some challenges in different countries in Asia. So, for example, in India, guidelines have been laid down by the Indian Council for Medical Research, ICMR, Government of India for providing minimum standards of care, prevention, survey of disease prevalence, and training health services. The Ministry of Health, Family Welfare has launched the pilot phase of the National Program for Prevention and Control of Diabetes, Cardiovascular Disease, and Stroke. This is one of the effort in India. In Nepal, the Nepal Diabetes Association has active in diabetes detection and awarenesses raising programs. A number of challenges, including issues related to the maternal and fetal nutrition and pregnancy and diabetes, have been identified, which are most linked to cultural practice and beliefs. Next. Next. Okay, the challenges in Bangladesh, the diabetes prevention study, joint program of the Diabetic Association with the Bangladesh and the University of Oslo, Norway, to prevent type 2 diabetes in subjects with impaired glucose tolerance has recently been completed, funded by the World Diabetes Foundation. The objectives of the project have been to raise public awarenesses about diabetes, to train doctors to improve national healthcare capacity, and to develop a national policy of diabetes prevention with endorsement by the Minister of Health. Culturally suitable strategy for creation of awarenesses have been developed. Next, please. Next. In Sri Lanka, the National Diabetes Center for Sri Lanka, with the collaboration of the scientists at the King College, London, UK, has reported a high prevalence of risk factor for type 2 diabetes in youth, an adult aged between 10 to 40 years. The study is part of the research program aimed at creation of awarenesses and developing methods to prevent diabetes in young Sri Lankan. Next. Next. This is the Healthcare in Gulf Cooperation Council country in the MENA region, a review of challenges and opportunities. This study was undertaken to review the healthcare status in the Gulf Cooperation Council, GCC, member of state, and explore current challenges and future opportunities. Next. So there is a challenges and opportunities in health services delivery and workforces, healthcare financing, informations and research, public-private partnership with the consumer and community, public health and clinical leadership, and strategic vision. Next. proven and effective action to tackle diabetes join in the national effort. Diabetes prevention and management can be improved with strong health system. This is a very important point. Number two, there are interventions and lifestyle changes that can improve the health outcomes of people living with the risk of diabetes. Everyone can play a part in preventing type 2 diabetes. It's not only the government, not the private sector, but everyone. This is the responsibility for everyone that can play a part of preventing type 2 diabetes, raise awareness of pre-diabetes, and also this is a very important point, promote the national DPP as a covered health benefit. Next one. This is the last slide. Thank you very much for your listening.
Thank you very much. After that wonderful overview by Dr. Hamak, we know that retinopathy is one of the leading causes of blindness in the world, and it's a complication, it's a dreaded complication of type 2 diabetes. To share her overview on the future prospects of screening of diabetes retinopathy, I now call upon the next speaker, Dr. Shehnaz Karadaniz. May I have her? Yeah, thank you. Dr. Shehnaz is a professor of ophthalmology at Istanbul Florence Nightingale Hospital. She's a founding member and a board member of Turkish Diabetes Foundation. She's a president and of Living with Diabetes Association, and I welcome her to please give her talk. RX events.
Is Dr. Shehnaz joined yet, or I don't see her name?
Ria, RX events.
Yes, ma'am.
Is Dr. Shehnaz here?
No, ma'am. No.
Program will go a long way in really taking a little bit of a hold of the calamity that we are all facing today. In the post-COVID era, it's really gone exponentially high. So I think we need to have some good intervention so that we can take care of the future diabetic patients as well.
Definitely. It has to start from the prevention, from the basic of it, not only decreasing the burden of it, but we have to plan and see the future aspects, that it should not further increase the burden of it.
Absolutely.
Not only type 1 patients are increasing, but type 2 patients have exponentially gone up after the COVID. It may be because of the steroid therapy or the lifestyle, whatever it is, but they have gone extremely up, as we have already seen in the data which sir told us.
Yes, absolutely. And I think we are special people, being the thin fat Indians, as we put in. And in fact, the Kerala Diabetes Prevention Program has published a data showing that 1/3 of the population actually has a normal BMI, but a very high fat level. Fat percentage is quite high. So that means just by checking the height, weight is not enough really for us to screen diabetic patients as well. So I think we need to go beyond it. And I think the adolescent obesity is a big worrying factor now, because everybody is glued to the screen like how we are today. I know I think that's something which is really worrying. So I think intervention should start right at the children, at the school level now.
Definitely. If we convince somebody to eat healthy, it is actually they are taking it as we are telling them to be on a diet.
Absolutely.
The normal diet has completely changed.
Absolutely agree. Absolutely agree. And unfortunately, the fast food is,
A basic diet.
a big way. And initially, in the early stages, the rural population was quite healthy because they used to have home cooked food. But now, I think with the spread of the media and the availability and the advertisements, I think everything is available everywhere, and that's where we are going to land up in problems. So similarly, if you talk about retinopathy, I think a wonderful thing that a colleague of mine and I was doing was we were screening retinopathy in rural India, and then you send across the pictures and we get it evaluated from an ophthalmologist. So I think that's another way that we can help being glued to the screen in a better manner rather than increasing our BMI. So, have you had any experience? Do you routinely screen for retinopathy in your patients as well?
Yes. We routinely do it. Actually, if there is no risk factor about it, we do it yearly, and otherwise every 6 months.
Perfect. I think early intervention is the key, because they do not realize they do not have symptoms, and that is what is a major drawback of diabetic complications.
Yes.
So I think yeah. Go ahead.
The first thing when we tell the patients to go for any kind of screening, their first response is, "But I'm fine."
Absolutely. I think that's the biggest hassle that we are going to face every time, because they don't want to check. They don't want to check for complications, and they feel it's a waste of money. But there are numerous patients who are diagnosed in the early stages, and recovery is much better. And the prevention to complete blindness is sort of, restricted to the early stages. And then that is where I think we score over in treating the patients rightly and correctly. So
Yes.
I think counseling is the key in every aspect here.
Yes, to give equal amount of time to all the patients and make them aware that whatever is happening is just the screening part of it.
Absolutely. I think that's one of the major things that comes into picture. The second thing is the food labels, because I think Indian government also should involve themselves more in food labeling, because there are so many food labels which are available, but most of us do not know how to read them. So if we can simplify it, and then you can tell them this is the amount of things that are there, even in whatever best we can do, because we are a carbohydrate rich country, and we are a sugar rich country as well. So whether it is good occasion, bad occasion, good omen, bad omen, everything has to start with a sweet. So I think if we can involve the government in such a manner that we can make the people have an informed food. So it need not be a diet food, but they can at least be informed. Like for example, right now wheat is the main culprit. So everybody is talking about wheat. But if you ask me personally, I don't think wheat itself is bad, or anything in moderation is acceptable if a patient is not diabetic. So I think we have to make the patients aware about all of these programs. And I think the best way out is the social media, because there are a lot of information, a lot of wrong information by wrong people looking out for clicks and likes and subscriptions. So I think that is where I think if we can get the government involved in some manner, I think we can do. And I think RSSTI is doing a wonderful job at that. Banshi sir is doing a wonderful job at that, where you're having patient education programs going on at every point on social media. So I think that is a wonderful.
But people have to understand the mindful eating habit part, because after the entire counseling, the only question, but can I eat this? What was the session about then?
So true, so true. I think you hit the nail on the coffin. So I think, yeah, that is, I think, where we probably lack a little. So we need a little mindful eating, as you properly said. Ria, RX events.
Yes, ma'am.
If you talk about, let's talk a little about diet. So, what do you diet and exercise? I think form the basis of any prevention program that we can talk about. So, I think we need to instill that feeling in the mind that it is not how much you walk, but how much you exercise, how much time, how much speed. But I think it is more to do that you have to keep moving. If you can keep moving, I think that's the way to go to prevent any kind of non-communicable disease in the future.
Lifestyle diseases, yes.
Absolutely. So, for example, if you talk about a couple, one can walk at a pace where he can cover probably 5 kilometers in an hour, and the other one can probably cover only 1 kilometer in an hour. And then there is always a fight between them. So you have to count the number of steps rather than the speed of the steps or the distance of the steps or the time per se taken to finish that amount of work and exercise. I think that forms a very important aspect as well.
Yes, that can be inculcated from the childhood, but I do agree with you, ma'am, but I also agree that some patients can just feel like they can run away. They can burn the diabetes by running, which is also not true.
Absolutely, I agree. In fact, most of the patients feel that if they do diet and exercise, their sugars are going to go away, and they will not need the harmful, as we put it, the medicines that are available with side effects. So I think overall, diabetes is a lifestyle disease. So we need to incorporate a good amount of diet, exercise, planning right from the start. Unfortunately, what happens is when the kids are young, they are playing a lot, and then they come into 9th, 10th, and 11th, 12th, and then they are busy either studying or they are busy socializing. And that puts an end to their sports activity. And we see a number of sportsmen who are playing on, district level, state level, national level, and then they suddenly go into jobs, and then they're sitting on the desk, and then they have no time to exercise. And these patients, I think, are more prone to develop lifestyle diseases than the people who have been moderately sedentary, moderately active all throughout their lives. So we need to incorporate that as well into the picture.